At 50, your body and medicine were speaking the same language. A threat appeared, you treated it, you gained years. Clean logic, it worked. But something changes after 70 that almost no doctor takes the time to explain. The biology shifts, the timeline shift, and the tests that once protected you start operating on assumptions that no longer apply to your body. I'm Dr. Marcus Adebayo, physician and cardiologist. Today we're going to talk about what that biological shift actually means for the test on your checklist. When you were 50, catching something early made perfect biological sense. A fast-growing tumor found early, you treat it, your body recovers, you live decades longer. That logic rests on three assumptions. First, the condition will progress fast enough to cause harm. Second, your body tolerates the treatment. Third, benefit outweighs harm. After 70, all three of those assumptions start shifting, sometimes dramatically. The same disease, a completely different biological reality. Conditions that were dangerous at 50 may be slow, stable, unlikely to cause a single symptom before the body meets a completely different fate naturally. And treatments themselves, surgery, radiation, intensive medication, carry risks that scale with age. An 80-year-old body does not recover from major intervention the way a 50-year-old does. Kidneys process contrast dye differently. Anesthesia clears more slowly. The immune system responds to surgical stress with less reserve. These are documented physiological realities, not opinions. There is a concept in medical research called lead time. It refers to the window between when screening detects something and when symptoms would have appeared naturally. In younger patients, lead time is your ally. Find it 10 years before symptoms. Treat it. Change the outcome. Powerful medicine. But lead time can be an illusion. If a condition is detected early but would never have caused symptoms regardless, the lead time bought you nothing. It just gave you more years knowing you had a diagnosis, more anxiety, more follow-up, more side effects, with no actual change in outcome. Researchers call this overdiagnosis. And it is most prevalent precisely in the age group where screening is most aggressively applied, older adults. Studies across multiple cancer types show a meaningful proportion of screen-detected cases in older adults represent overdiagnosis, findings that would never have harmed the patient. That word, undiscovered, feels uncomfortable. We are conditioned to believe knowing is always better, but knowing has a cost. After 70, that cost belongs in every screening conversation. Today, I want to walk through 5 specific tests where these biological realities are most consequential, where the gap between what screening promises and what it delivers is widest. Let me start with the test that sits directly at the intersection of biology and overdiagnosis. The PSA test, prostate-specific antigen, a simple blood draw. In the right clinical context, genuinely useful. In routine screening of men over 70, biologically problematic in ways that rarely get explained. Here is the biology that matters. PSA levels rise naturally with age, not because something is wrong, but because prostate tissue changes as men get older. A PSA reading that signals concern in a 50-year-old may simply reflect normal aging in a 75-year-old. The number looks the same. The meaning is completely different. The majority of prostate issues detected through PSA in men over 70 are what clinicians call indolent, slow-growing, hormonally stable, unlikely to spread within the patient's remaining lifespan. Autopsy studies consistently show significant numbers of men over 70 who died of unrelated causes were carrying undetected tissue changes meeting the technical definition and never caused a single symptom. These are issues a man dies with, not from. But PSA cannot reliably distinguish these indolent findings from genuinely aggressive ones at the point of detection. So when PSA comes back elevated, the pathway moves toward biopsy. Biopsy carries risks, infection, bleeding, and measurable cardiovascular anxiety effects in older patients. If biopsy confirms abnormal tissue, the pressure toward treatment becomes intense. Surgery, radiation, hormone therapy, each carrying significant quality of life side effects. Incontinence, fatigue, bone density loss from hormone suppression. For an issue that was never going to shorten that man's life by a single day, the U.S. Preventive Services Task Force reached a clear position. Routine PSA screening in men aged 70 and older is not recommended. Before agreeing to a PSA test after 70, Ask, what proportion of findings at my age are likely to represent slow-growing disease that wouldn't affect my lifespan? Ask for that number. Mammography has one of the most powerful track records in modern preventive medicine. For women in their 40s and 50s, the evidence is substantial and I respect it completely. Younger breast tissue tends to harbor faster-growing tumors where lead time advantage is real and meaningful. The biology supports screening strongly in that age group, but breast cancer biology changes with age. And this is the piece that mammography conversations after 70 rarely include. The biology shifts in a specific direction. In older women, the cancers most commonly detected are disproportionately hormone-sensitive, slow-growing tumors. Biologically, less aggressive than those screening catches in younger women, more likely to respond to simple hormonal medication, more likely to represent overdiagnosis, findings that would never have announced themselves during the woman's remaining years. Mammography in older breast tissue, which tends to be less dense, actually produces more false positives proportionally. Imaging finds irregularities requiring follow-up that generate biopsies. Biopsies carry procedural risks that scale with age, bleeding complications, infection risk, physiological stress in a body with less biological reserve than it had at 50. And if a finding is confirmed, the treatment machinery activates regardless of the tumor's biological behavior. The protocol doesn't pause to ask how slow it's actually growing. I have seen women in their late 70s navigate surgery, reconstruction, and radiation for tumors that every biological indicator suggested were slow, contained, manageable with medication alone. The treatment was heavier than a disease, and the recovery consumed years of the life it was meant to protect. That is a biological failure of proportionality. The practical question: bring this to your doctor. Given breast cancer biology in women my age, what is the realistic range of findings and how would we approach each one? That question reframes screening from a binary yes or no into a genuinely informed biological decision. It is the conversation the appointment should start with. As a cardiologist, the carotid artery story is one I feel particular responsibility to tell clearly. The biological paradox at its center is one of the most striking in medicine. The carotid arteries run along both sides of your neck, supplying blood to your brain. Narrowing, plaque buildup inside the vessel wall, is associated with stroke risk. That association is real. Carotid narrowing in a patient who has already experienced stroke symptoms, sudden weakness, speech difficulty, vision loss, is a genuine indicator. Intervention is supported by strong evidence, but carotid narrowing in a patient with zero neurological symptoms is a fundamentally different biological situation. The plaque is present, but it is stable. Stable plaque in an asymptomatic older patient tends to stay stable. The annual stroke risk from untreated asymptomatic narrowing, even significant narrowing, is lower than most patients imagine. Clinical trials measured this carefully. Annual stroke risk from stable asymptomatic carotid narrowing managed with medication, approximately 1 to 2% per year for most patients. Now compare that to the procedural stroke risk from carotid surgery. Combined stroke and death rates during and after these procedures in real-world settings, 2 to 5% for a single procedure. The math is uncomfortable. You are front-loading significant risk in one intervention to address a risk that was spreading itself thinly across years. The American Heart Association guidelines reflect this biology directly. Routine carotid screening in patients without neurological symptoms is not recommended. The biology simply doesn't support widespread intervention. Optimal medical management addresses the underlying vascular biology without concentrating procedural risk into a single high-stakes intervention. Blood pressure, lipids, antiplatelet therapy where appropriate. If carotid screening is recommended and you have no neurological symptoms, ask specifically, what is the annual stroke risk managed with medication versus the procedural risk of operating? Side by side, in numbers. Speaking as a cardiologist, cardiac stress testing is one of the most valuable tools I use, and also one of the most consequential sources of unnecessary intervention in older adults. Let me explain the biological chain reaction. A stress test measures how the heart responds to increased demand. In patients with symptoms, chest pain, breathlessness, palpitations, critical information. The biological problem emerges when it's applied to older adults with endocardiac symptoms. Because in this population, the test false positive rate rises substantially. And the reason is rooted in biology. Older hearts develop structural changes that are entirely age-appropriate. Mild wall thickening, subtle relaxation changes, minor electrical variations. Normal aging biology. These normal aging changes produce stress test findings that look abnormal to the algorithm, flagged as potential ischemia, in hearts functioning perfectly adequately for daily life. A false positive result in a 72-year-old generates a referral to coronary angiography, a catheter threaded through the artery into the coronary circulation. Angiography carries procedural risks that scale with age. Contrast nephropathy in kidneys with reduced reserve, bleeding in patients on anticoagulation, real risk of stroke or heart attack from the procedure itself. And if angiography finds narrowing, which it frequently does in older adults, because some coronary atherosclerosis is nearly universal at this age, the pressure towards stenting becomes intense. Here the landmark biology becomes impossible to ignore. The COURAGE trial and the ischemia trial, two of the most rigorous cardiovascular studies of the past 2 decades. Both examined stable coronary disease, no acute symptoms. Both found the same result. Stenting and bypass produced identical rates of heart attack and death compared to medication alone. Identical. The procedures added procedural risk without adding biological benefit in terms of the outcomes that actually matter. The biological chain runs like this. A normal aging heart produces an abnormal result. Abnormal result triggers angiography. Angiography finds age-typical changes. Changes trigger a stent. The stent adds procedural risk, and the outcome, heart attacks, survival, quality of life, is statistically the same as if the patient had taken their medication and gone for a daily walk. The question before a routine stress test, biologically precise. Given no symptoms, and what the evidence shows about intervention in stable patients my age, what changes if this comes back abnormal? If the honest answer is probably not much, that answer should inform whether the test happens at all. That is not avoidance. That is biological reasoning applied to a real decision. Bone biology after 70 is genuinely important. Fractures in older adults, particularly hip fractures, carry serious consequences. The mortality statistics are sobering. This is not an area to minimize, but there is a specific biological disconnect in how DEXA scanning and its downstream prescribing plays out in very elderly patients, and it deserves honest examination. DEXA measures bone mineral density and produces a T-score, comparing your bone to that of a young, healthy adult. By that comparison, almost every person over 75 will show some bone loss, because bone loss with age is biology. It is normal physiology. The question is not whether it's happening, it is, but whether the degree translates to fracture risk. Medication can meaningfully address. Here is the biological problem with automatic prescribing from DEXA results in very elderly patients. Bisphosphonates inhibit osteoclasts, the cells responsible for bone breakdown. Over years of use, this inhibition can paradoxically weaken bone differently, producing atypical femoral fractures from disrupted remodeling. The medication creates a different fracture risk through a different biological mechanism. The timeline biology matters enormously. For bisphosphonates to reduce fracture risk, studies show 3 to 5 years of treatment are typically required to demonstrate benefit. In a patient aged 82, the medication needs to perform across years 82 through 87. Weighed against gastrointestinal side effects and the atypical fracture risk, the biological calculus is complex. What the biology actually supports most strongly for fracture prevention, addressing the mechanism, the fall. Muscle strength and neuromuscular coordination are the biological variables most directly linked to fall prevention. Balance training improves proprioception, the body's sense of its own position, directly reducing fall incidence. Home modifications address external triggers. Protein supports muscle maintenance. These interventions work upstream of the fracture. They interrupt the biological chain before it reaches the bone. A DEXA number by itself addresses none of this. If a DEXA scan is ordered, ask specifically what fall prevention plan accompanies any prescription. That biological question is at least as important as the T-score itself. Everything so far has been about what to reconsider. Now let me tell you what the biology genuinely supports, because this is not a picture of less medicine. It is more precisely targeted medicine. The cardiovascular biology of aging makes blood pressure management non-negotiable. Hypertension damages arterial walls through a specific mechanism, Sustained pressure increases arterial stiffness. Arterial stiffness increases cardiac workload, elevates stroke risk, and accelerates small vessel brain damage linked to cognitive decline. Controlling blood pressure is one of the most direct biological interventions available. Lipid management remains biologically relevant, particularly with established cardiovascular disease. The conversation about statins for a specific older adult is worth having carefully and revisiting regularly. Vision and hearing. The biology here is consistently underestimated. The vestibular system relies on integrated input from vision, inner ear, and proprioception simultaneously. Degraded visual input from uncorrected refractive error directly contributes to balance instability and fall risk. Hearing loss affects spatial awareness and cognitive load simultaneously. The biological link between sustained hearing loss and accelerated hippocampal volume loss is now supported by enough research to be taken seriously as a brain health concern, not merely comfort. Vaccination biology is straightforward and the case is strong. Influenza in an older adult is not the same biological event as influenza in a younger one. The inflammatory response is dysregulated. Recovery takes longer. Secondary complications, pneumonia, cardiac stress, are substantially more common. Pneumococcal, shingles, updated respiratory protection, biologically justified at every age over 70, and the biology of polypharmacy, one of the most underappreciated risks in older adult care. Drug metabolism changes fundamentally with age. Hepatic clearance slows. Renal filtration decreases. A medication dose for a 60-year-old liver may accumulate to toxic levels in an 80-year-old. An annual review of every medication, asking whether the biological justification still holds, is genuinely protective. I've given you the biology. Now let me give you something you can use in the room. Because biological knowledge only changes outcomes if it makes it into the conversation. When you bring biological reasoning into an appointment, when you ask questions grounded in how your body actually works at your age, you are not challenging expertise. You are activating it. You are inviting a more precise application of your doctor's knowledge to your specific biological situation. Good physicians welcome that. It makes their decisions more meaningful and more defensible. First question, always, is about biological relevance. Given my age and health, does the biological timeline of this condition mean it is likely to affect my quality or length of life? This is the lead time question in plain language. It cuts directly to whether finding something early changes anything real for your specific body at this specific age. Second question is about biological tolerance. Given how my body processes treatment at my age, what are the realistic risks of the intervention that will follow a positive finding? Not whether treatment is risky in general, whether your specific physiology, kidney function, anesthesia tolerance, recovery capacity interacts safely with the proposed intervention. That is a biological question that deserves a biological answer. Third question is about biological alternatives. What does the evidence show about managing this condition with medication or lifestyle versus procedural intervention in patients my age? This opens the door to the trial data I've described throughout today. The courage findings, the carotid asymptomatic evidence. Your doctor knows this data. Asking invites them to apply it to you specifically. Fourth, ask about the downstream biology. If this test finds something, what is the realistic next step? And what does that next step's evidence base look like for someone my age? The cascade is biological. Each step creates its own risks. Understanding the full chain before entering it is not excessive caution. It is informed consent in its truest sense. Your body after 70 is not a failing body. It is a body operating on different biological parameters, different timelines, different tolerances, different risk profiles. Medicine at its best recognizes those parameters and works with them. You deserve medicine at its best. And these questions are how you ask for it. Here is the biological truth that underlies everything I've said today. Your body at 75 is not your body at 50 running slower. It is a fundamentally different biological system with different timelines, different tolerances, different relationships between what we find and what it means. That is not decline. That is biology. The most dangerous thing in medicine is not ignorance. It is the confident application of correct knowledge to the wrong situation. The knowledge that PSA screening saves lives, correct in the right population. Carotid intervention prevents strokes. Correct in symptomatic patients. Stress testing reveals cardiac risk. Correct in symptomatic patients. All of it true. All of it valuable. All of it potentially harmful when applied without biological precision to a 78-year-old body operating by different rules. This is not a criticism of medicine. It is a description of medicine's current frontier. The field is actively working through these questions. The trials I've cited represent medicine doing exactly what it should, but the gap between what research shows and what happens in a 15-minute appointment is real. And you are living in that gap right now. Every time a checklist generates a referral without a biological conversation. What I want you to carry from this video is not anxiety about tests. It is biological confidence. The understanding that your age is relevant clinical information you have every right to ask about. You are not just a patient. You are a 70 or 75 or 80-year-old person with a specific biological profile. The medicine you receive should reflect that profile precisely, not approximated from a guideline written for someone 20 years younger. That precision is available. It exists in the data, in the research, in the knowledge your physician carries. The conversation you have at your next appointment is what unlocks it. And now you have the biological language to start it. Let's close with the biology that matters most. 5 tests where the biological shift after 70 changes the calculation significantly. PSA Screening, where age-related prostate biology and the prevalence of slow-growing disease mean a positive finding often costs more than it protects. Mammography after 70, where breast cancer biology shifts towards slower tumors and where the treatment pathway can outweigh the biological threat it addresses. Carotid artery screening without symptoms, where stable plaque biology and procedural stroke risk can make operating more dangerous than the condition itself. Cardiac stress testing in asymptomatic older adults, where normal aging heart changes inflate false positives and landmark trials show intervention adds procedural risk without improving outcomes. And DEXA scanning after 80, where treating a T-score rather than a person leads to medications whose biological side effects rival the fracture risk they were prescribed to reduce. None of this means stepping away from medical care. It means stepping into it more fully, with biological understanding, specific questions, and confidence that your age is information your doctor should be using. Here is your action step. Before your next appointment, write down this single biological question and bring it with you. Given my age and biology, what does the evidence specifically show about this test or treatment for someone in my age group? One question, every appointment. It changes the entire conversation. Tell me in the comments, has understanding the biology behind a recommendation ever changed the decision you made? I read every response. Your experience might be what someone else in this community needs. If this biological breakdown was useful, share it with someone whose next appointment deserves a better conversation. The biology I've described today belongs to everyone it affects. One essential reminder. Everything discussed here reflects current medical evidence and my clinical perspective as a physician and cardiologist. It is general information about biological principles, not personal medical advice. Your specific health history, current conditions, and medications create a unique biological picture that only your own physician can fully assess. Before making any changes to your care or declining any recommended screening, please have this conversation with your doctor directly. Grounded in your specific biology. That is always the right starting point. I'm Dr. Marcus Adebayo. Understand your biology, ask the right questions, and know that informed engagement with your healthcare is the most biologically sound thing you can do at any age.